Great. Good afternoon, everyone. It is Tuesday, it is not February, January 23rd. Welcome to the House Healthcare Committee. We are taking up for the afternoon the fiscal year 2023 budget adjustment. So the plan will be, we're going to start with Department of Vermont Health Access, or DVHA. Claire put on everyone's desk a chart of all the items in one spreadsheet, and then we also have the talking points that are online that we went through a couple of days or last week with the commissioner of DVHA. So I think what we'll do, we're going to start with DVHA because we also have Representative Page in the room with us. So please jump in if you have questions. And we have no testimony. It's going to be a committee discussion. We'll answer questions the best we can, and we'll walk through each one and just say, yes, we agree, or no, we don't agree. Sound like a plan? Yes. All right. So the first one on the list is and I'm going to look to Alyssa to help us with some of these. The first one on the list is the Transitional Housing Complex Care Management. It is $200,000 in state money, and this provides the estimated backfill for the loss of federal funding to the Vermont Chronic Care Initiative staff. One of you have anything else to add to that, Alyssa?
Nothing other than that it was already appropriated for this, and they just need this to get through because of the loss of funding.
Federal funding. Okay, any questions on that one?
I'm sorry, does this follow this, or is there, it's
chart,
line to line?
spreadsheet?
The spreadsheet is actually in the order of what's
Let
on
me get the right thing up.
The talking points.
Got it, thank you.
Okay, where is that?
The talking points are on our committee page on.
I brought them up under the witness for the commissioner, Andrea.
Or what date, Claire? Do you have a date?
What day?
January 19th.
January 18th and 19th. 19th.
Okay. Gotcha. Perfect.
I think it's the 19th.
It says the narrative.
Yes.
Yeah, got it.
All right, gotcha.
All right. So, okay.
Thank you, that's helpful.
Yep. No, absolutely. Sorry for not clarifying that. So the second one is
Are we gonna do a yes, up, down, or?
I think on the little ones, we'll just wait till the end. If there's discussions, we're going to wait till the end on DVHA unless there are discussion points that we feel we need to vet with the committee. So the Agency of Digital Services service level agreement. This is an increase to the cost of services provided by the Agency of Digital Services to DVHA. So if you remember, the Agency of Digital Services works with all of the agencies across state government and charge them for their services.
Do we know the budgeted level of any of these so we can? It'd be interesting to know the percent of increase that we're asking for here.
So we don't have that readily at our fingertips. We would need to go back to the original fiscal year 23 budget and look at that line item.
Okay.
I don't have it in the top of my head, and I don't have my papers with me.
Okay.
But you guys do have that or not?
I believe we do, yes.
Yes, I would have that.
Yeah, you have it. Okay. All right.
Part of this, remember, Art, is we do the policy. Appropriations does the money.
Say that again.
Our committee does policy, right? So we make the policy decision on whether or not these programs and these requests should happen. And we look at the money as part of that policy, but appropriations really determines the money piece of it.
Right, but when we approve, yeah, I get that, but when we approve these things, we're approving the money.
we are approving the money, but then it'll go to appropriations and then they will look at it as well.
We're approving
Okay,
the concept.
okay.
Right.
I
We
understand.
aren't the final.
Okay,
decision
we're
makers.
we're just saying then that the reason for it is sound.
Yes. The reason for it is sound. The policy is something we support.
Okay, and then they'll take and look at the percentage of money and
Right.
see if it's, I get it. Okay.
Okay. All right, so the next one is the Medicaid data warehouse and analytics solution. We had some follow-up testimony I sent out to everyone today from questions we had asked. And Alyssa, I don't know if you have any comments to make.
This has been an ongoing project. It's not anything new. I'm actually gonna, if you don't mind, defer to Daisy.
Sure.
Because Daisy actually knows this program quite well.
So Daisy, I think our questions originally, and we may not have them anymore, was, is this an ongoing project? Is this something new that's happening? I believe it's an ongoing project and it's required. So if you just want to provide your synopsis overview, that would be great.
Yeah, I think it is a very important project because it is a project that will allow ongoing improvements of where all of the Medicaid claims data is housed. So clinicians might recognize this as MMIS, or the Medicaid Management Information System, and this is sort of the evolution of that system that'll allow not only the claims data, but also more clinical level data to be held in a space that is safe, and we all know from events that have happened in recent years that when it comes to data security and safety, as well as learning from the data that's in there, is something we really want to maximize. So I agree with Lori that the explanation that the commissioner followed up her testimony with is pretty comprehensive, definitely much better than I could articulate. And I believe the committee has that, and I don't know if Claire posted it, but yeah, I was quite satisfied with it, and the fact that this project has been underway since 2020, I'm comfortable with continuing to invest in it. It's pretty central to the majority of Vermonters, since most of us are covered under Medicaid. Alyssa, would you add anything else?
If I recall, this was just a pass-through, wasn't it?
It was a carry forward from 20.
Carry forward.
Yeah.
Leslie?
I'm sorry, I didn't see an email. I saw an email from BA, a follow-up, but it had to do with mental health and not, I don't see this, and maybe I didn't get it or I missed it or whatever.
It was an email from 10:21 this morning.
I have 29.
Lori.
Do you want to, can you read what she said?
I see it now, thank you.
Okay.
Okay.
Joe?
Just to follow up on Alyssa's point, according to my notes here, that it is a net neutral. So it's moving AHS money to DIVA, so it is net neutral.
Well,
Sorry.
it's a carry forward.
Yeah, but they also said, I've written down here several times that they said that it is net neutral in the sense that it is just sort of AHS money moving to DIVA without, anything else. So that's what yeah.
All right. Art?
Yeah, will this system, just so I understand it, will this save us administrative monies and programs and stuff in the future? Is that what the purpose of it is? Daisy, I mean, or whoever can answer.
Well, I feel like that we have a couple clinicians on the team who might be able to speak to that, Art, better than I could, but I just know, looking through the mental health provider manual in there, where directions are given as to how to code things. At the end of the day, when folks at our agencies who ultimately do those pay claims back to our providers, the faster they can get that money back to our providers, the better for everybody, right? And when it comes to facilitating implementation of things like we've heard about the last couple weeks, like the all-payer model. The faster we can pivot to make those changes, the better. And I think having modern technologies to do that is something that I'm certainly invested in, and I think this enables that. Does that make sense to you?
Yeah, I mean, you're the expert. I'm the dummy sitting here trying to figure it out. But
I don't know about
you're telling me,
No one
you're
is.
telling me it's good and it's needed.
But yes, and I think also having garbage in, garbage out. That's all, that's kind of my mantra when it comes
Okay. No,
to
that's
using data.
fair. It's, a fair amount of money, that's all, but yeah, okay.
All right, any other questions on the MDWAS? MDWAS, is that what I was trying to remember what they were calling it, MDWAS. Okay, then we're gonna go to the big one, which is the caseload and utilization changes, which, as we said during testimony, this does happen yearly. So as we get to half of the year, we look at the caseload and utilization changes have to be made. We have the written explanation, which we can walk through again if we want. I didn't know if anyone had any questions on this one in particular. Wait a minute.
I do have one question. It's a clarification.
Sure.
That just if the state spends the $17,906,606 that we're pulling down federal money, that's why the gross is $44,993,000. So what that's saying is for the investment the state makes of approximately 18 million, we are pulling down about 35 million. Wait, is that I don't know if I'm
We're
mad.
pulling down 45 million.
No, that's gross though, so it's
Oh, yes.
So 25,
So
25 and 60.
25, not 35, yeah, okay, so that, just the point is that for the investment we make, it allows us to pull down a lot more to support the services we're providing people.
Yes,
Okay, thank you,
absolutely.
just wanted to clarify, I understood it to be that, but I think for the
Yes.
record, it's important to clarify that too. That these investments we make with state money are drawing in a massive amount more of federal money.
Exactly,
Yeah.
yes. Art,
Just so I understand this one, I'm sorry for the.
no, that's why we're doing this.
Is this and I forget the word we used, the repurposing of the Medicaid
Redetermination.
determination?
No.
This is not that.
This is not that. This is caseload and utilization for the Medicaid population.
Okay, it's a lot more, it's taken a lot more money than we anticipated.
But,
Hold on.
I'm sorry.
No,
For the record, Noel Lang, Joint Fiscal Office. So this is budget adjustment. So what this is saying is we estimated caseload lower than what it came in at. Actual caseload came in higher than we projected in the initial budget. That we need $45 million gross to cover the
Okay,
caseload.
that's what I thought.
Yes, so we're.
All right. So it's just what it says it is. Yeah, thank you.
much better said than what I did, Jeff.
But is it
Thank you,
still,
Dylan.
is it okay? Is it still fair to say though, that we're spending 18 million more and 27 million is coming from the federal government towards that gross? Okay, just wanted to be clear that, all right.
Okay, so then we go to the annual Medicare buy-in and caseload changes. 431,000 from the state, 1.3 million gross. Again, this is a annual process we go through at BAA for the buy-in on Medicare on behalf of duly eligible beneficiaries. Questions? Okay, cruising. The next one is the Graduate Medical Education Supplemental Program. And if you remember during testimony, they talked about this, they do this every year. They are increasing the amount in this BAA I believe because we no longer have the cap, and so we're able to draw down some additional funding.
I don't know if it's because of the cap, but I think that
We're able to draw down some additional funding.
Anything that gets us more providers, especially since we're drawing down federal money,
Right.
is I'm great with.
Questions?
I do have a question.
Sure.
Are we gonna write a letter like we normally do based on this decision today of reviewing this? Is there gonna-
Yes,
Okay,
so we have legislative counsel with us, and I think we're going to try to do a chart like we've done in the past. So it's a couple years, we did a letter, and then the last couple years, we ended up basically just saying, in this chart, approve, not approve, because it's easier for everyone to follow. Does that work? Yeah.
it does. If there happen to be, and so new members may not know what I'm talking about, but if even though it's money, we make policy statements sometimes in the budget. So if there is I don't see any yet, but if there's any policy statement we want to make, might it be in the notes?
Correct.
Okay, thank you.
Or we'll add language to the bottom of the chart.
Great, thank you.
Yes, absolutely. And so, again, this is budget adjustment versus budget. And so during the budget process is really when we talk a lot more about policy. This is policy and things that are already in process here in the BAA. So there'll be more of those, more than just approved next to many of them when we do the budget. Art.
Yeah, on this one, it says this proposed funding mechanism does not require additional general fund dollars. Where does the money come from?
So the money comes from UVM to the state, which then draws down the federal funds.
Gotcha.
And then it's used for the residency program
Oh,
to increase the pipeline of physicians in Vermont.
okay. Thank you.
Sure. All right, anything else there? Okay, the next four we'll kind of group together, but it's all Brattleboro Retreat. So we had number 7, which was the year 2 appropriations budget shortfall for Brattleboro Retreat. Number 8, which was retroactive to July 1st of 2022, part of the alternative payment model. And it increased the per diem rates. 9 is a shift to global commitment, which is $0. And then number 10, which is the Brattleboro Retreat funding shift to the general fund. And this is part of the phase down of the IMDs that we have to do each year. So are there any questions on any of those? Or Melissa or Daisy, if you have anything to add, or Nolan? This is why we started with Diva, because it's easier. All right, number 11. Annual Medicaid rate adjustment. So DIVA has a goal to be a reliable and predictable payer for Vermont Medicaid participating providers. And so this is annual rate updates are developed using established rate methodologies, and this is an increase to those, an increase based on that. Anything?
I have written down that this is a mandate from the feds.
I have a question about this.
Sure.
We heard testimony from a couple of folks, a couple of entities, including the home health agencies, right? From Jill.
Wilson, yes.
Aren't they asking for an adjustment? Can you help me understand that, Lori?
Right, so we will actually work with Jill Olson's ask separately. But yes, they are asking for adjustments as well. So that's, although we could clump it into this one, I'd like for us to keep it as a separate ask.
Okay.
Can it go in with the budget adjustment?
Yes. Yeah, we're going to talk about it. Yeah, just trying to keep the two separate. Maureen?
Same with Vermont Medical Society, did they have an ask?
They did not have an ask.
Okay.
Hey Laura, it says by state says this is not adequate on the notes.
Right, so do you want to do it?
Well, that's what I was thinking of by state.
You were thinking of
not
by state.
EMS.
So by state came in with a separate request. They did not come in here. We received written testimony from them and they did testify in front of appropriations. Did you wanna?
No, I had actually put that on the spreadsheet just because I had seen the email. I think you had forwarded the email. So they testified in another committee on this. I just put that little blurb in there.
You know, I think what might be something we could do specific to what Brian was saying about how we can put our position in writing. I think I believe that our Medicaid rates are not high enough in many areas. And so we could just put a simple statement saying that, you know, anytime we can increase Medicaid reimbursement rates where appropriate, we encourage House Appropriations to look at it or something to that effect. What do people think?
That's exactly the kind of thing I was hoping we could do, so I appreciate you brought it up.
Yeah. Did you have something to talk about?
Yeah, I'm trying to formulate it.
Okay, yeah, I'm not good with wordsmithing, so we'll let you think. Leslie?
I'm just thinking in taking Brian's statement that it's really where we get to do policies in the big budget, and that would be a real place that I care about, that we talk about Medicaid rates. Just to have that on the table. In the budget adjustment, I'm not sure where it fits in.
Well, I think a statement here.
Statement's always good, yeah.
It also establishes a record of our intent. So I think we should, every chance we get, the healthcare committee should be like, calling out the injustice of how we've been financially like unsupportive of the healthcare system, and also how we've not spent money well, but we'll get into that another time. We can get into that one later.
So let's, Amron, you have that tagged. We'll come back to wordsmithing it. Let's just keep moving through. So any other, Joe?
Just on that point, because I looked at, and I just pulled up again, the written testimony that was sent to Approps. And if that's something we're going to be discussing, it would be, I think, great to have this person in to give more information, because while they did say that, the quote is, does not come close to closing the gap between the cost of providing Medicaid covered services and the reimbursement healthcare centers receive, doesn't, at least I can see here, really go into what that change would need to be in order to effectuate this. So I'd be very curious to hear what those specifics are.
That's by state you're talking about.
Yeah, by state, excuse me, as the written testimony provided by state to appropriations.
So why don't we plan on this? We don't have the time for that in this BAA, but we can absolutely have them come in while we're talking about budget.
Thanks.
Yep. I'll make a note of that.
So my question,
Sure.
Chair, is if we make that statement, that global type statement, is that going to do anything to this list that we have
No,
in terms of, okay,
I don't.
putting it in terms of eliminating anything on here, eliminating anything that we kind of straw vote to do?
No, because what we'll do after we're done with this is we'll prioritize
Okay.
certain items. And so we can, make sure in that prioritization, the things that are in the BAA that we, definitely want. But I think this is more just a blanket policy statement that we want other people to know about.
Okay, that's good.
I'm good.
Lori, this item, it's 11 on the sheet that was sent us. Is this the sum total of the Medicaid underpayment or just this piece of it?
This is not the sum total.
I wonder.
Me here.
It looks relatively insignificant.
Right.
Well, relatively.
Right, so this is specific to increases for FQHCs, rural health clinics, and hospice services effective January 1st of 2023. So the very last line
Okay.
in that write-up. Nolan, I don't know if you have anything to add?
No, I think you got it.
I think what you're thinking is higher up, this really big number that Lori said.
Caseload and utilization.
Yeah, caseload and utilization, look at number, what is it?
9.
4.
Okay, I just get balled.
No, I get it.
I get more balled up in the word
I know.
used than anything else.
So, yeah, right there.
All right.
See what?
Okay, that's the underpayment.
Uh-huh. That's the need that hasn't been funded.
Okay. And by doing these things, are we attempting to supplement what the folks get from Medicaid? Is that what we're doing?
No, we are attempting to pay for the Medicaid utilization and caseload. So we're not supplementing, this is, go ahead, Nolan.
This is an attempt or proposed by the administration to increase their rates.
To increase the rate.
Increase the rates mid-year.
So
So wait,
that,
I want to make sure we're talking, are you talking about number 11? Or are you talking about number 4?
I'm talking about, well, potentially both, but let's stick with 11.
Okay, so go ahead. That was,
11's a rate increase, 4 is just meeting the needs of the base.
Okay. So this is a rate increase, 11. The other is
Paying our
just a
bill.
shortfall of any kind
It's just.
for Medicaid because we got too many people. Okay. So other Medicaid, we said this is just for this,
number 11, yes.
okay? And are we making it comparable to what it costs to provide the services?
I think by state would say absolutely not.
Okay, so it's to a certain level
Yes.
and then that's it, okay. All right.
All right, number 12 this is one of those, we have to do it, it's a contract. So this is the Vermont Medicaid Next Generation Accountable Care Organization Program initiative. And so this is the amount. DEVA has contracted, sorry, I'm talking and trying to read, so I'll just read. DEVA has contracted with OneCare Vermont to participate in the Next Generation Program. And each year, DEVA and OneCare agree on the cost of care financial target for attributed Medicaid members upfront. And so this is the payment that is due to them. And then the next item is a carry forward offsetting amount.
I do have a question about the ACO settlement. That means that we owe the ACO 2.7 million more than we estimated. If that's not fair to say, you can clarify, I'm trying to understand
What it
it.
is that, if the ACO hits benchmarks, we pay them, and I think they hit their benchmarks.
Yeah.
Or maybe I'll defer to somebody else, but this isn't us under projecting, it has to do with meeting they met the contractual requirements, and so
It's like their bonus.
it has to do with the risk.
Yeah. We can have them back.
Yeah,
We
we'll understand, yeah.
We will have one Karen to better understand this. I would try, but it's like risk here and I don't want to.
I think I know what it's leaning towards, but I would defer to a witness to clarify for us so that we don't get it wrong.
Right.
But I'm just.
Brian.
Go ahead, Dave.
I did ask this question of the commissioner of DEVA when we met, and she did indicate that it was actually a payout for their underspending, so they spent less than projected.
So they spent less, so we have to pay them more?
You have to appropriate more so that they can pay that out to providers for.
Right, it's for the providers. It's not to one
It's not to
care.
one care.
One care distributes it to the providers that put in the risk. And then it's distributed to them once a year if they meet.
So it's the reward that we funnel through the administrative apparatus of the ACO to the providers for doing a good job and like managing their case as well, so to
Yes.
speak. All right.
I think the concept of risk is hard and.
It is.
Really worth having a
When you say
conversation.
that, I don't get it.
Yeah, because we don't understand.
And remember, some years it's the opposite,
Right,
so.
exactly, right.
So what does it mean to take on risk in this context?
Yeah.
I don't think we understand.
Yeah, and we haven't had one Karen, so we need to do that.
Okay.
This is a contracted amount, so.
So yeah, when they come in, that's a question I have. What's the accounting rationale behind it? Why not put more upfront if we're gonna anticipate they're gonna meet their goals and get a risk adjusted payment?
Yeah, and I want to know what their cut of this is too, you know, for being the middle person. So.
There is no cut. But we will have one Karen and we will discuss
Okay,
it
what
with
the
them.
cost, administrative cost is
Yes,
for funneling. Okay.
Just want to read something from my notes here, which was I have a note on this, which says it's not allocated for on an annual basis. So it sounds like it's something that they just don't budget for because they don't know where, what target will be met. And
Right.
so therefore, it's the budget adjustment when they actually then sort of, I guess, have that point in time analysis that determines that this has happened. So it sounds like this is a pretty normal
It is normal. It can,
Exactly obligated.
yes, it can flip, which either way. Very nicely said, Joe. Thank you for stepping in on that. Okay, so that is all the DEVA recommendations that came from DEVA. I think I want to take a moment and do a quick straw poll on these. Actually, let's not. Let's go to the additional request first. So we had in, I'm going to forget his name. I think his first name was Jim, from Vermont Public Transportation Association. And if you remember correctly, they provide, the association is up here, and then there's organizations down here that provide the transportation for Medicaid patients to where they need to go. And they are in a gap of 1.7 million to be able to provide those services. And if you remember when he came in, he talked about how they're paid. So contractually with DEVA, how they're paid is per member per month. So if I'm a member, per week. If I'm a member, right? And so they get paid to take me to my transportation. It doesn't matter how many times, they get paid one time as a member. And what they have seen happen is that their members have dropped off, but the members they still have need more transportation. And so the rides are increasing and the cost is obviously increasing. I mean, one factor alone is gas that we can all relate to. And so, and I'm going to turn it over to Alyssa in a minute, but so we reached out to DEVA because again, this is the Medicaid general fund versus federal funds. And so although believe they need 1.7 million, our state amount is $739,202.50. Okay, so that if we move forward with putting this in the BAA, our recommendation to House Appropriations, it would be $739,000 request. So I don't know if you wanted to add anything else, because I know you had looked. You don't have to, but I know you had asked some questions about it.
I just had some questions around actual numbers of rides that they're giving. And I mean, I believe they had less members in 21 or more members in 21 than 22, but they gave a couple 10,000 more rides in 22. So
they're getting paid less.
Yeah,
because the
they're getting
members are
paid
less,
less.
but they were doing a lot more
They're doing a
work
lot more rides.
to get those people where they need
With
to
higher
go.
gas prices.
Do you remember what their service area was?
It's all over the state.
This whole state.
It's all over the state.
It's all over the state. And so the VTPA has the contract with DEVA, and then they work with the other organizations throughout the state. So I don't know who it would be specific to
Well, we have
your
Green
area.
Mountain Transit at home. It's a bus that does that.
Right.
They go to Richford anywhere needed. So same organization.
It is one of the
just a
organizations
different
that,
Contract company. It's-
right. So VTPA does the contract, and then they work with all the local agencies. Yes, Mari?
And just to reiterate what we heard, or I heard and passed on from the Office of the Health Advocate, was the downstream effect of lower capacity but increased need was that people, the rides aren't getting to people sometimes when they need them, so they're missing their critical doctor's appointments. And one example was someone having to not have dialysis that day and had to have it rescheduled for another day in the following week, which is not a good thing for someone with kidney failure to have to do. That's not wise. And there was another thing, but I don't remember what it was. I would like to mark it as a priority, and I would like to add more, give them more, because I think it's a critical part of our healthcare system.
So I would say, as much as I would love to give many people more, this is what they asked for, so let's stick within that parameter.
Maybe the appropriations committee can hear what I'm
That more
saying.
should be added. Leslie?
So my concern about this is policy and structural. I don't understand why Medicaid has this design for taking care of their own patients and getting them where they need to go as part of this transportation model. I mean, if we think about social determinants of health, and I'm gonna, once again, transportation is huge. And I think that DEVA should have this part of their budget. Now, clearly they don't today, but I would like to mark this as something that we should put in our budget. Yes, when we think about a large budget, as transportation funding solidity, whatever that might look like. Because I think it's, like Mari said, I think it's crucial for people's health. And it's poor people that can't do it, right? It's not rich people who can get a ride. It's people who can't. And I think it's important.
I believe, and maybe I'm conflating different budget items, but I believe in the contract negotiations that are upcoming.
Yes.
They are changing the methodology of payment.
They are currently working, they just signed a contract with VTPA, right? And then they're working on the next contract. And so there are discussions happening, which if it's something our committee wants to take up at some point, we can. Right now, this is what they've asked for.
No, I totally get that, but I just want to get it in our
To your
heads.
point of social determinants of health, yeah.
Unfair or wrong, or however we want to call it.
Joe?
I just want to highlight two aspects of the written testimony from VPTA that I think are really important to the discussion. First is the first paragraph of the written testimony. It says, federal rules provide that transportation providers participating in Medicaid transportation program must take any and all Medicaid eligible individuals who are in need of such services. There is no ability to deny such transportation except for complete withdrawal of the program in its entirety. So I think that's important to highlight. And if you look at the very last sentence under impact of deficit, which is on page 2, at its most extreme, losses are unsustainable and may force individual providers to leave the NEMT program, potentially leaving Medicaid eligible individuals unable to obtain their necessary and entitled healthcare rights. So to me, it's a no-brainer.
Yeah, if I may, it's just unsustainable in this model, and really want to think about how to make it a more sustainable model as we go forward.
So Amran, I don't know if you caught what Joe said that first, and maybe we can talk offline, but that might be good to put in as part of the policy as we're suggesting. So
It was the first two sentences in the written testimony and the last sentence in the written testimony.
can you please send that to Amran? Do you have the written testimony? You don't have the written testimony, Amran.
I have it.
Can you send it, Joe, to Amran?
So the first two sentences
And the last sentence.
Yeah, that they might have to withdraw.
Comments?
I'm good.
All right, so I'm not hearing any reason not to put this in. Daisy? Any thoughts on?
No, I agree. It's absolutely essential.
All right, so let's move to the next one, which is the VNA request. You have
anything.
They did. Hold on, let me find this one. That one is probably from Jill. So this is the request. If you remember, Jill Olson came in and talked about the various levels of care they provide. So they have the skilled nursing, or if you remember the chart, skilled nursing or healthcare. So these are nurses, other professionals who go into homes and take care of people, all age groups, right? So it could be they need rehab after a surgery, they need monitoring after a surgery, whatever the case may be. And then there's the home health group, which are not licensed, and they are mostly helping, and Mari, you might be able to help me out on this one. They are mostly helping the elderly in their home to help take care of themselves. And in both cases, I think the key for this committee, in both cases, that is helping people keep people out of the hospitals. We all know the hospitals have overcapacity right now. So this normally actually isn't something that would have come to this committee in the past. With how we're working with Human Services now, they have also heard this testimony and we'll be discussing it as well. But again, because of the dynamics with the flow of our system, I think it's important for us to have the conversation and decide what to do with it. And so it was $422,000. With federal match dollars, it would be 1.1 million. So this would bring the home health service payment to 90% of Medicare. So it's not completely matching it or covering the cost, but it's 90%. And this 422,000 or the 1.1 million gross is specific to the skilled care. So this is the medical care at home from nurses and therapists.
I'd just say to this one that I can get behind this one more than any of the others. I think this is extremely important.
I've had personal experiences with it. So.
Yeah, okay. Anyone else?
Yeah, the fact that this one, really reaches across the whole age span, I think is really important.
Nolan and then Joe. Joe, go ahead.
I was just going to point to written testimony again, sort of the why of this, as they say in their written testimony, was that they're working towards this 90%. And they said that the last increase, it says, they're making the VA request as DBHA transitioned the time of skilled home health rate increases to January 1st. And it goes on in the last sentence of the third paragraph to say, the last increase was effective January 1, 2022 is included in the BAA. The 2023 BAA does not include an expected January 1, 2023 rate increase that would have made more progress towards the Medicare target. So I think that's an important reason to go for this one.
Great. And Ameren and Nolan, I just sent you the request.
And actually, to piggyback on what Adriana said, because it's been in January, you're going to get this again in next BAA.
Right.
Unless they include it in their notes.
Well, and so that's a really key point, actually.
They will include it in BAA or they won't.
Right, so, and then I need help on this one. So this, we could put it in as a one-time ask and then we'd be in that situation. Or we could recommend can we recommend in a BAA that this becomes part of the base? It is not a one-time request.
So I need help, if I may, distinguishing between what we put in the budget and what we're putting in the BAA.
Yeah.
So what do you, when you say the base, you're saying what we're putting in the budget? I'm not getting it.
We're putting in the fiscal year 23 budget, which is what we're in right now.
Right.
Right.
If we agree, we're saying we're gonna add $422,000 general fund for home health skilled nursing
For this year.
for this year, and this year goes until June 30th of 2023.
But we do have the option of taking our 24 fiscal year budget and make it 90% of Medicare right up front so that we don't have to deal with it in BAA next year.
But I think that operated on a different fiscal year.
Right.
What you could do is in the letter, you can say, where we agree with this and we encourage it to be base funding going forward and not annualized.
Okay, then I want that.
Got that in mind?
What you're trying to do is include it in the
Going forward,
going forward.
Yeah, exactly.
Because the timing of it is why they keep
coming back.
having to
So you approve this and put the policy statement.
Yeah.
people put it in there.
Okay.
Joe?
Yeah, just to answer Leslie's point there, it seems that this is happening because there has been some sort of change in policy, and it's not clear to me when that change in policy occurred, to do the rate increases on January 1st, that says, quote, to align with hospice increases and the timing of Medicare rate changes for skilled home health services. So it seems like it might be a challenge to actually do it as a continuous thing, just because we have this policy that says that it's January 1st, it's a rate change that seems to align with some other rate changes that are occurring, so.
Right.
Medicare's rates change on January
January
1st.
This is a fiscal
Yeah.
year crisis.
Right.
That's, yeah.
Right. Okay, and then the last one is the American Heart Association, which we received a letter on. We did not take testimony. Again, they went into appropriations. This is to provide funding to schools for CPR training. They also made the request of the Education Committee. So without much testimony, I'm apt to let the other committees work with it at this point, unless someone has some really strong desires or.
So I mean, we could say that we're putting that to the Education Committee. We support it, we're supportive, but
Or we're not against it anyway.
Right.
So, but yeah.
Yeah, so I mean, I'm supportive of it. Teaching people to do CPR is, especially students, is great, but we didn't take any testimony, and so I would want to be clear on that in our response.
I thought they submitted written testimony, did they not?
They did submit written testimony, yes. I should say we didn't have them come in and provide testimony.
And it was 30,000, was that right?
Yes.
Yeah.
And they addressed their written testimony to House appropriations.
Yes. Okay, so that's DEVA. So that's everything that touches DEVA. So I want to try and close this out, except for maybe some of our comments before we move to DMH. And so one of the things we're supposed to do per our letter from House Appropriations, so I'm just going to read through this. If you choose to respond to any provision, please indicate the following: whether the committee supports or does not support, indicate how high a priority it is, make any suggested changes to the proposed funding or language, and offer any additional suggestions to be incorporated. So we are offering 2, potentially 3 more to be incorporated. I think we all agree everything they submitted, a lot of which is contractual, cannot not be done. And we have to prioritize. So what I would suggest we do is what DEVA submitted in the budget, because most of it is contractual. I don't think we need to prioritize that. I think we need to say it's contractual and it should be done. So what I think I would like to do though, and this is where it gets hard, is we prioritize the transportation and the VNA request as a 1 and a 2. We want both to happen.
One is high.
That we want both to happen, but if we only have the option of one, this is the one we're going to choose, right? See, Joe, it's hard, isn't it?
I'm gonna push back a little bit. Why can't we approve two? Why is it that we have to sort of pit those against each other? They seem equally important.
Have to. We can choose to say we want both and then
leave it up to the appropriations committee to see what.
That's why they get paid the big bucks.
Yeah.
I prefer if you made a choice.
Of course you do.
that we make a choice.
Maybe appropriations will split the baby.
Right. Right. Nolan?
In the past, the committee has prioritized.
We've always prioritized. Well, except for 1 year, I think we. So I think we should prioritize. With an emphasis in our written language that we would like both.
No, that's hard. I'm not, yeah. Past behavior doesn't predict future performance, whatever that statement is.
Are you ready?
I was listening, but
I know, you always are listening.
I don't miss.
We're gonna prioritize for a 1 and 2, 1 being the highest priority between the Vermont Public Transportation Association and the VNA request. But in our writing, we are going to emphasize that we want them both.
So I didn't miss anything then?
No.
But I wanted to comment on that. That's why I ran here.
Okay.
I don't know if we have to prioritize if we take into account that there was a massive amount of money marked to be used for education that didn't get used. However, it passed through the workforce bill, which went through commerce. So I'm wondering if they might be able to, if appropriations might be able to look at how much money we're not going to use that we appropriated to workforce development that might be able to be used to supplement the VNAs at least. If not the Transportation Association, so that we don't have to prioritize, so that we can have both. I just like kind of a thought.
Right, so again, remember, we do policy, we don't do the money. And so I think our commitment and our prioritization should be based on the policy with, again, the stated fact that we would like both, if that's what we agree to. And we'll let appropriations before they get the money to do it, if they want to do it. But to your point, there is money that, yes.
I would like us to do both, but since we're being forced to make a choice, I'm going to make an argument for the choice that I would make.
Okay.
But for the record, I want to say that I 110% think that both should occur. My argument is going to be for the VPTA. And my reasoning for that being the higher priority is because of, according to the written testimony, the potential of a cliff in this program. So the written testimony indicates that it's an all or nothing program. Either all needs to be provided or the program needs to be shut down. And again, that was the language I quoted earlier. There is no ability to deny such transportation except for complete withdrawal of the program in its entirety. So that means if it reaches the point where it can't happen anymore, then it stops for everyone. Also based on the final sentence, which I quoted earlier, but I'll say again, final two sentences, impacted deficit. VPTA members have no ability to cost shift as may be possible for other Medicaid providers. At its most extreme, losses are unsustainable and may force individual providers to leave the NEMT program, potentially leaving Medicaid eligible individuals unable to obtain their necessary and entitled healthcare rights. Would note in other areas of the testimony, it talked about the importance of this. We talked earlier about the impact on some patients of not being able to make dialysis treatments and things like that. That has downstream impacts on outcomes of health. It also has impacts on further causing delays in the healthcare system, because if someone can't show up and doesn't know until that morning, then that was a space that could have been used for someone else to move the healthcare system along. So I do think that this is essential. I am not going to sit here and make arguments against the VNA because they need it, they deserve it, and I think and it is distressing to me that I have to sit here and pit two essential things against each other.
Yeah.
But if you're going to ask me to pit two essential things against each other, rather than fighting that as I would like to fight, because I think my colleagues have already said why that's not good. That's the argument I'll make for VPTA.
And just know, I don't like.
I'm not saying you like it. I know you're doing what you need to be doing, what you're supposed to be doing, and so I'm just gonna move this stuff along by making that
And
argument.
I think it's good for us to have a discussion and then we'll just see how it plays out, Leslie, and then Maureen.
So Nolan, could you help me for a second here? What's the DEVA budget?
Total budget?
Yeah,
Oh, and
it's
then,
like $1 billion.
Well, the total Medicaid spending is 1.9 billion.
1.9, okay, so we're talking about a DEVA budget that's $1.9 billion. And I say 739, I mean, this adds up to about $1 million. It's trivial, okay? And if we're not taking care of the people that are being served by these programs, one is not better than the other. It's not a zero-sum game in this world. We can support two good things. That was a trivial amount of the entire DEVA budget. And that I am not going to be able to rank them, just saying. Sorry.
I'm also a troublemaker. I can't and won't. We need both of them.
yeah. Brian?
Yeah, I feel the same way. And I just wanted to clarify that there is a policy decision involved with this money decision. So I would propose, like, and this isn't a formal motion, but it's like putting it out there, like that we say something akin to what Leslie said, that it doesn't have to be a zero-sum game, and that and that the committee believes that the money needs to be found to support both these initiatives. And then the other thing is that we made a policy decision to invest in the workforce, and my understanding is that the VNA's money is going to the workforce, right?
Well, it's the rates for the providers.
Yeah, and so if we can't, the policy decision is if we can't use money to recruit people, the least we can do is raise the rate so we can retain them. And I think that is a policy decision. It's not saying necessarily where the money's coming from, but it's saying that we're going to invest in retention of staff and in maintaining these important services on the back of what we did last year, and considering that, and this might be where I'm pushing the boundary though, is saying, considering that we didn't spend all the workforce development money, if there's any way that pieces of that money could be used or even like given to the nurses doing this work.
So I want to say, we haven't spent the money yet, right? So the workforce money hasn't gone out the door yet, but the intent is that it will get out the door. So, you know, to tie it to, I really appreciate where you're coming from, and I think there is other money available out there. I just don't want to put in writing that we're going to tie it to that workforce money, because
In case it gets spent.
our intent is to get that out the
Okay.
door, as is the administration's intent, is to get that out the door.
Okay.
Alan?
Okay, up home, you know, I deal with the people that I know.
Yeah.
The visiting nurses are tremendously needed. Okay, it's rural area. A lot of times, a lot of these people do not even be able to get to the transportation across the rural places. So the others, the people that do need transportation, if it's not available, majority of apart home gets a ride. You've got friends, you've got neighbors, you've got legions, guys that go, will do this stuff. So it is crucial. I agree with both of them, but I think because of the nursing home shortages and everything else, the visiting nurses are tremendously important.
Art?
Yeah, I'm gonna vote for the visiting nurses over the transportation, just so you know.
Okay. Anyone else have anything? Joe?
So I'll say about the visiting nurses, we saw in testimony from AHS that, one of the problems in our system is not places for people to go. And I'd asked a question during their testimony about how they play into that. And they basically said they don't right now because they're doing okay. But if they don't have money, then limits come. And so then we begin to actually see an increase in the number of people languishing in the hospital because they don't have a place to go out to, which is, again, why I want to say that I agree, with Leslie and Mari and Brian that, we ought not to be forced to make this decision. Can
I add something?
Yeah, please, Daisy.
I would prioritize the nurses because I think that the transportation model needs to revisit the business model. I think everyone is challenged right now with staying in the black, but I think, just reading their outline, I think with declining membership and all of those challenges, it's ripe for just revisiting their structure. And I'm remembering back a couple years ago with the DAs getting behind in their payment rate and how hard it was to get them back on track. And I feel for the nurses. I think Brian articulated it really well, and keeping staff on track with an equitable rate is critical. And once you get behind, it is so hard to get caught up. So I think keeping them at that 90% rate is really critical. I'd hate to see folks fighting for this next year or 2 years from now, because it will be that much harder to get them back up to speed. So I would prioritize the home health nurses.
Thanks, Daisy. I'm going to go to listen.
I appreciate everyone's sentiment about not wanting to make a choice, but I just want to remind people that not making a choice is a choice. So wanted to say that, but also I'm going to make a choice, and I'm going with VNA. Don't forget, this is cheap money. Think about how much it saves in other costs. If visiting nurses are not going into people's homes, these people are in skilled nursing facilities, and that's really, really expensive, or they're sitting in hospitals, and that's even more expensive, and there's no room in any of them either way. This is cheap money.
I'm also going to go with the visiting nurses. And the reason for that is, number one, the impact of the work that they do on society. You have people in those homes that need wound care. You have people they need all kinds of care. If they don't get it from the visiting nurses, they're going to have to stay in the hospital, and that's not going to work. The hospitals are low on beds now anyway. So I think we need to get them out of the hospital. That has an impact on the hospital and the individual, which we know it's better to be served at home if that can be done. They can be served at home. So that's one. Number two, goes right along with that, the individuals that are impacted by the work of the visiting nurses will be much better off in the final analysis because they're healing at home. And we all know that if you can do that, it's a better place to be. Now, having said that, I'm not against the transportation thing at all. But if I have to make that choice, I'm going to go with the visiting nurses because I think it has a much bigger impact on individuals.
Brian and then Joe.
So, once again, this isn't a formal motion, but what I would propose is that we demand that, or recommend, I suppose, because we can't demand, but that we strongly recommend that the Appropriations Committee find the money to fund both. In order to ensure access to healthcare, we must fund services that both bring providers to people in their homes and bring people from their homes to providers. That would be the language I would want to put in there, the policy language, that we must do both. We can't choose one over the other. And so please find the money. And I also would like to point out maybe that for the investment of 1.1 million, we draw down 2.8. So it's a worthy investment to be able to provide both, and that's all. So I strongly urge that the committee consider voting to do both, that is a policy statement, the way I just phrased it. And I am hopeful the Appropriations Committee would be moved by that and find the money.
I like that statement. I see a lot of shaking heads, so let's give that to Amron before we're done.
You can read it off.
Joe and then Leslie.
So I wanted to say that I find the arguments convincing and I would, if again forced to make a choice, change to the VNAs based on the arguments others have made. Although I do want to just again point out that it would be very troubling if we were to lose the transportation thing because of a deficit. And so yet again, it's important that appropriations realize what the implications of a choice could be to prioritize one of these programs against the other, against the health and safety of Vermonters. But I do also want to just sort of point out something that troubles me, again, in VNA's written testimony, which is that why didn't DVHA include this in their recommendations for budget? It was done in January 1, 2022. It was not done for January 1, 2023. I find that troubling, and I wonder, is there a way to have some sort of bill or something that would require it to, a shall be of 90% of the Medicare fee-for-service fee schedule, rather than having to hope that this occurs and every year they come back to us. And so is there a way to do a shall bill?
Right, so I think that goes back to, we are putting in the request that it, continues, depending on what the decision is made, we can take it up in budget. Yeah. And to your thing, and to your question about why it wasn't in there, we're not quite sure, so I don't want to comment unless we're sure, but, some of it is, discussions between DIVA and the providers that we're just not aware of. But
if you remember the testimony, I think she said, I don't think. She said we put it in, but it was taken out.
So they put in the request
but it wasn't included
to DIVA, but DIVA didn't include it. Okay.
Yeah, that's unfortunate.
So I'm gonna, if you don't mind me just making a suggestion before, do you want to say something before I make my
I don't know
suggestion?
suggestions, so I can't say.
Go ahead.
I just wanted to say that I'm abstaining on this vote, and I've never done that before in my second term. But I think pitting these two programs against each other is unfair. And I think your statement is great because it really looks at two very different populations that have different sets of needs and that we are responsible for them through this DIVA, these requests. Not DIVA. Yeah, DIVA. So I'm going to abstain because I am not going to be sort of forced to make a choice against something that I think they're both worthy and they're both trivial. And so in that, I will be abstaining because I believe both.
Let me give you my suggestion. Okay. And then maybe you'll change your mind, I don't know. Based on what everyone has said, there seems to be a camp of not choosing, not prioritizing, and then if we do prioritize, VNA would be number one. What I would like to suggest is with the language that Brian came up with, the one sentence, which I thought was very good, we put a 1A and a 1B. And so it's not a 1 and a 2, it's a 1A for VNA and it's a 1B for transportation when we, Daisy and Alyssa and I will be going to present in front of appropriations and we give the feedback that we would like both of these, but because we were asked to prioritize, that was our prioritization.
So it's going to make people laugh probably at first, but when U.S. News and World Report ranks colleges and they tie, it'll be number 1 and then number 3 and number 3 and then can we just say number 1 and number 1 or does it have to?
Thank you though.
Okay. But I think it's important that we do a priority.
Yes, they've asked.
Right.
In writing, Intercat, how high a priority.
And I agree. The second one is as important, but if the other committee says we're not gonna do both, we pick one. I think we have to be on record which one we want.
Well, and just for the record, I would hate that the appropriations committee to be sitting there when they've asked for our guidance
Mhm.
and make a decision not to do either one of them.
Yeah.
You're right.
Right. And this is not an easy seat we're in. I mean, it's not. Of course, we believe both of these are really important. We're asking to bring them in to BAA when they were not in there originally. So I think it's a very difficult decision, but it is the role we have.
This is a clarification question. We weren't asked to prioritize anything above that.
I am asking us not to prioritize because those are mostly contractual obligations. And so on this one, I'm just asking us to prioritize the ones that we're adding.
Thank you.
My question is, do we know if BPTA submitted its, request as well?
My understanding is that there was a discussion before the contract was signed at the end of December around this additional money needed, yes. And it was not put into, yeah. Whether it was requested, remember the budget happens earlier, so whether either of these were requested at the time before the budget was created by the administration, I don't know. I know both were discussed with their appropriate parties. Okay, so I'm going to take a straw poll on my suggestion, which don't, do what you feel is best for you, but that we use the language Brian came up with and we'll work with Ameren after we're done to get that all sorted out. And that we prioritize VNAs as a 1A and VPTA as a 1B with the full support of the committee saying we really want both.
Clarification question. Does the straw poll go to appropriations other than the people that are hearing it?
People that are hearing it, and we will take it to appropriations.
So that
We are going in Thursday morning to present.
And they can watch YouTube if they need proof.
No, I believe that. I know what they're
In their spare time.
fully trust our leadership here. That's 10-minute philosophical.
I think my point is it's not documented in writing, but it is now documented in electrons.
Yes.
All right, all those in favor, raise your hand. 1, 2, 3, 4, 5,
Well,
7.
no.
Okay, Daisy, are you,
I
sorry.
withdrew my vote. I'm confused.
Okay, we're voting on putting them both into the BAA, right? And we're going to say, can you repeat your sentence?
In order to ensure, in order to ensure access to healthcare, we must fund services that both bring providers to people in their homes and bring people from their homes to providers.
And then we are going to say we list the VNAs as 1A.
Is that now it's top priority?
Top priority. The VPTA is 1B. I know I'm splitting hairs, not saying 1 and 2, but I think it looks, they're both priorities. And as leadership, myself and Alyssa and Daisy as the committee liaisons to appropriations, we will be in there on Thursday morning and we will express our desire by the whole committee that they are both funded.
And point of clarification or information, like if we vote no on this and no motion carries, both of them won't even appear in our thing.
Correct.
Because they're not there right now.
Because they're not there right now.
So a vote of yes would be adding these to our priorities.
Correct.
And a vote of no means that there could be an alternative motion offer, but it may fail. And if all these motions fail, neither makes it in. Okay.
Correct.
All right. Then I do vote yes.
Okay, all those in favor?
All right.
1, 2, 3, 4, 5, 6, 7. Daisy, I can't see. Oh, you can't vote. Okay, so.
It's a struggle.
It's a straw vote, exactly. Okay, so that's the plan for Diva.
7-3.
Yep.
So if it's 7-3, meaning no, or 7, because I don't want to vote no. I want to abstain.
I am
Is
going
that not an
to say the
option?
majority of the committee, our committee voted on this because it was the majority of the committee.
Right, but it could be, I guess.
I'm not gonna say 7-3. I'm just gonna say the majority of our committee
Thank you.
voted to move forward.
I just have
That makes
this,
sense.
I just have this sort of fundamentally physical thing about this, so I'm abstaining.
Okay,
I do,
I just want to explain why I didn't
that's fine. Yep.
vote for it. And not that you need my explanation.
No, please.
but I see the transportation thing as a clear two. Okay, I just feel that in this day, there's more than enough transportation for 99.9% of the folks to get to their appointments where they need to. That's the only reason I felt the other way.
Thank you. Did you have a clarification?
no, I think I want to talk at some point about, I don't want to derail us, but like about, my understanding is the rules say that we can't abstain from votes, so that's why people disappear mysteriously when they want to vote, don't want to vote on things. Yes, but it's because this is a straw poll, it doesn't matter, but I just feel like people need to know you can't abstain on the floor from a vote, like, yeah, so I just think,
I could disappear.
no, you don't have to, because this is a straw poll.
Very quietly slip out.
You express your opposition, so it's like.
Say yes and not, no language.
Okay. We're going to DMH. Amron, we can chat after, but are you good for right now? Okay, awesome. Okay.
Leslie.
Where are we going from here?
We are
Oh, the
going
next,
to Department of Mental Health.
yeah. This was the rubber meets the road.
So again, we have the talking points, we have the spreadsheet, and we have the talking points. Claire, any chance you can help me on the day for the talking points? January 18th, under Emily Hawes, probably. So now, if you remember on DMH, we actually did not get through all of their requests because we focused a lot of time on the 9.255 million for the youth inpatient beds. So we're gonna walk through these. Again, most of these are contractual obligations. Excuse me. Because we didn't walk through all of them, I'm gonna rely on Alyssa and Daisy. If there's questions, we just may not have the answers. But I do wanna spend a chunk of our time talking about the $9.3 million request, which, if you'll remember, is not in the talking points and it's not on the spreadsheet. Because in the BAA request, in the actual official budget adjustment that came from the administration to appropriations, it was just in the language, okay? So we'll get to that, but I want us to remember that we have to get to that because it's not on either document you're looking at.
This is the new,
The mental health beds and, so we'll get to that.
and why isn't it on there, Lori?
It's in the language, so along with all these numbers we're seeing, is they send this document, which you all have a copy of and is posted. And it's just the language. And if you have questions on why there's language and no numbers, that no one might be able to help us, but I'm putting that out there to now say, let's set that aside, let's focus on what we have for the numbers and let's come back to that.
Is this on a day from last week?
January 18th is
January
the
18th.
talking points.
Ups and downs at the bottom of the page, and the top is the memo on the facility.
19th, yeah.
So it's kind of split between two different people.
It's at the bottom of the page.
The bottom has the ups and downs document, yeah, and the top has the memorandum on the inpatient facility.
So yeah, it's Emily Hawes, to this one, this budget, the narrative, yep.
All right, I'll give everyone a minute to make sure we have everything we need. Okay, so we're doing the talking points, which coincides with the spreadsheet. So the first one is contract increases for UVMMC. Again, this is a contract. DMH currently utilizes a contract through UVMMC for psychiatrists and physicians in both the central office for the Children's Medical Director and the Vermont Psychiatric Care Hospital. So this is a contract. Do you have a question? Sorry.
No, I have no question.
And Representative Lumley is here to offer any insight as well or ask questions. So anything on that? I mean, that's is what it is. Then we have travel nurse contract increases. We talked extensively about this in committee. All hospitals are facing this. Unfortunately, it's a big issue and it's a big cost driver.
Lori, and I don't know if this is the time to ask this question. And this has nothing to do with these two items.
Okay.
General question about budgeting.
Yes.
It drives me crazy, quite frankly, when so much money isn't anticipated. Maybe it couldn't be, but maybe it was in there and appropriations cut it. And I'm trying to understand when we send a budget, especially when it's contract, and I don't know if this happened, but if it's contract stuff and it goes to appropriation, do they consider it being a contracted thing and thus just go forward with it? Or can they take and trim that? Not willy-nilly, I don't want to use that term.
So remember, there's two different things going on, right?
I understand.
So during the budget process, and Nolan, jump in here at any point. When we're starting the Daisy, I see you, or no, so give me a minute. When we're doing the fiscal year 24 budget or any full year budget, right? It comes from the administration, we put our recommendations in, and yes, appropriations will look at all aspects of it. Because we're in the middle of the fiscal year, we're looking at where there's ups and downs. Now, we're only seeing where we need more money.
Right.
But somewhere there's probably more money available.
Correct.
Right? So that's the difference. For this particular case, these are travel nurses.
Right.
That
Oh, I
were
understand.
not anticipated.
Yeah.
Does that help? And Nolan, I don't know if you want to add anything.
Yeah, I think that's right. It's like, you build a budget based on what you think the needs are. DMA is just saying, you know what, we need more. So they're putting it in budget adjustment. But also sometimes things happen during those business cycles where you negotiate a new contract per se in the middle of fiscal year. And you can't sorry, there's no budget, there's no money this year. It's like, sure, we'll go to budget adjustment. So things happen outside of that as well.
Nolan, do we see the other side where that we over budgeted? Do we see that in this?
Always. When we see where it's over budgeted or we didn't hit caseloads or whatever, that gets, it can go to carry forward, it can drop to the bottom line. Usually the administration will, if you saw money in carry forwards, that's the administration saying, we're going to use some of that carry forward to pay for some of this. Because when you adjust your budget, you have to find the money somewhere.
And actually the next one on our list is a good example of that.
Yeah.
So the next one is where 1.3 million of general fund is available because we haven't been able to hire
Correct.
permanent nurses.
Correct.
And so that will offset some of the increase we need for the traveling nurses.
Do we see every up and down though, or only significant ones?
We don't see,
I think what they're doing is what they're proposing the budget adjustment is change of policy.
Yeah.
And as it affects, they're not going to show, oh, look, this came in above, this came in over. They're just going to say, this is the change of policy. You'll see it if they're saying, we didn't spend all the money here, so we want to use this money here, then you'll see it. Otherwise, that money, let's say you budget $1 million for a program in a year and you spend 900 of it, that $100,000 will drop to the bottom line and be used as carry. They won't report it to you per se. It won't be in the documentation, but it's there somewhere. But that's sort of the moving pieces of the budget, right?
I'm just trying to understand.
Maybe what we can do, Art, when we start looking at the 24 budget, let's sit down separately and just walk through where you can find what you're,
Yeah, I pretty much get it.
Okay.
What I'm getting at is, it is easy to build a budget based on what you want it to be. But when reality sets in, you can really cause yourself a problem. And I just want to make sure that, and all we're seeing is our little piece of the
Right,
world.
all we're seeing is our little piece.
And so I'm just trying to understand.
Well, also, it gets into the ups and downs. If you can see what was budgeted, like what was the original budget, and then what's the difference from the budget and the bottom line, so that would show up. So it's just a matter of.
Okay, folks, come on, let's stay focused.
in the room, just saying that.
Let's stay focused. Daisy had a question or a comment?
Yeah, about the travel nurses. I had asked a couple of folks from AHS whether the ratio of travel nurses to permanent staff reflected at VPCH was the same as it is at the retreat. Has anyone seen a response to that question yet?
I don't think so. I don't think we have, Daisy.
Okay, well, I know they're listening, so I still haven't seen it either, and I'm just curious.
Okay, so hopefully we can get that answer for you. Did you still have something?
No, I mean, I did want to say that they had budgeted, knowing that they would have to pay travel nurses more. I know they didn't anticipate the number of travel nurses they needed. And ultimately, yes, I know it's $10 million, but that's what's keeping these beds open.
Didn't the travel nurses go from $200 to $300?
Yes, the cost went up as well.
Yeah.
Maureen?
To your question, Art, and the about how to budget in healthcare, it's a lot different to be able, there's a difference between being able to budget for widgets than it is for people who need healthcare. And even like in a hospital, the census changes, and how many people need healthcare, whether it's in a hospital or clinic or at home, and how much healthcare they need, the intensity of care that they need. It's really hard to predict that. So,
Okay.
It's
Well, that does help.
not the same as building a
Yeah.
budget for something that's maybe less unpredictable. And then the workforce issue, I don't know if any, some of this we could predict just because the workforce is getting older in healthcare, but I'm not sure if they could have predicted as much upheaval as we would have gone through.
Well, the other thing is with this, it's hard to tell what the overall number is, just get an idea of percentage here. This may be a very small percentage of change because I don't know, I don't know the overall
Right, the
number.
original number.
I believe because I had asked the commissioner this, so right now, 65% of their nurses, their workforce are travelers.
Oh, I
I
know.
asked her what it was last year, and I think she said it was somewhere around 57, 54, 50, it was somewhere in the 50s range.
This kind of concerns me, because I'm from a small community, I know a lot of the nurses. And the girls, most of them, are disgruntled with the fact of the difference in pay scale.
Yes.
So we're looking right now at 11 million, next year it's gonna be 21 million. Because everybody wants to be a traveling nurse because of the pay. So it concerns me that this isn't gonna stop.
It's very concerning, and it's very concerning for all of our hospitals who do not have the budget to pay for the traveling nurses. So yes, thank you for that, Alan, I agree. Joe?
Just in support of all this, I think another part, and Topper said this, but I sort of want to reiterate it, is that there's incredible volatility in the traveling nurse contract rate. According to some of the notes I have here, July 2021, cost was 76 an hour, September 21, $100 an hour. They mentioned at some point, I don't know what it was, the highest that was $225 an hour. So obviously there's a lot of volatility in this market, which makes it hard to do that. I also have a note here that they said their number one goal was to reduce the number of travelers by trying to give a $5,000 nurse sign-on bonus, trying to get people away from being travelers. So I wanted to point all that out. And I also wanted to agree with Art that I sort of wish this had the budgeted number on the spreadsheet. I would really like to, I agree with that. I would really like to see that too. It'd be really helpful. Maybe that's feedback to give to whomever the powers that be to create this is, but that, I agree with that. I'd really like to see that.
Leslie? I just think there's an interesting contrast in how we fund our staffs. So in the mental health world, we fund it through state funds because we have a Department of Mental Health and they have a whole bunch of staff that we're responsible to pay for. In the hospital world, it's all funded through the hospital budgets, which is funded through premiums, which is funded through Medicaid and Medicare and commercial. So you have these two very disparate systems that are in fact funding very similar things, which is nursing staff. So we see it here because we have contracts, Department of Health, we have no input at all of what happens on the hospital side of things. But the same thing's going on the hospital side of things, which is why we're seeing premiums go up and why we're asking more for Medicaid reimbursements and all that stuff. So it's almost the same question. It's just because the funding pathways are so different, we're seeing it for mental health, but not for hospital care.
I do want to, that's a very good point. I do want to clarify one thing. So this is for Vermont Psychiatric Care Hospital, right? So the designated agencies, which is the system of our care for people who need assistance, is not funded. They're funded by Medicaid. And so you said, and the reason I would clarify is that you said how mental health is funded versus how hospitals.
Inpatient.
And they do cross, right? And there's still, so we're trying to do integration and there are beds within hospital systems. So, but to your point, yes.
We never see those budgets. That's my point.
Green Mountain Care Board is responsible for hospital.
Totally different mechanisms for payment. We're responsible for this particular one because it goes through the state budget.
Right.
But they're looking at the same projects.
Okay. So understanding that we're all frustrated with potentially not knowing the original budgeted number, let's move on. So the vacancy savings to offset travel nurses, that's savings. And then the next, sadly, for us, I apologize for this, the next several we did not hear testimony on because we spent so much time on the youth inpatient beds. So the first one is Washington County Mental Health Services is looking for support salary increases at their micro residential, which is a community-based staffed living homes for children with significant needs who are at risk of institutional care or may be transitioning from a higher level of care. So again, this goes to ensuring that children have a place to go with a staff who can support them. And so this is a small increase to the Washington County Mental Health Micro Residential.
Are you considering this contract, like you're saying this is a given, it's not, let's say a 1 and 2. This is a given.
In my mind, the fact that DMH is coming in and asking for this for one of the designated agencies is vitally important.
But we could prioritize it.
We could prioritize it, yes.
Okay, I'm just contrasting it to our last conversation.
Yes. S3 VLA, so Act 57, an act relating to competency to stand trial and insanity as a defense. DMH received a one-time appropriation in fiscal year 22 to cover the cost of additional legal staff and evaluations at Vermont Legal Aid, as well as the anticipated cost of conflict counsel for DMH. This is the estimated cost of this activity for fiscal year 23. So if we don't do this, that goes away. The ADS service level agreement, this is the same thing we saw in DEVA, probably different numbers, where it's the Agency of Digital Services is doing work for each agency, and this is how they get paid. The next one is private non-medical institutions increase. So this is the state of Vermont funds a network of treatment facilities for children and adolescents with emotional behavior and other challenges through something called private non-medical institutions for residential care, child care, which is part of the state Medicaid program. This is something that was obviously in the budget in 23, and it's an inflation factor adjustment to increase the treatment portion of the final rate for each provider. So it's to help them continue with these programs for children and adolescents.
Can I ask a question?
Sure.
So then the factor goes into the next budget? That'll be.
This is a one-time inflation
Yeah,
factor.
So then it'll go back to the previous level? It's what, I just want to understand that one time.
Nolan, can you help with that?
Sorry.
We're on the private non-medical institutions increase. This is a one-time inflation factor adjustment, meaning it's just one time. It's not going to be in the 24 budget.
Because one time not base.
So why, well, I'm not saying yes or no, or yes, I have no opinion yet, but why would we do a one-time inflation factor now if it's not an ongoing, it's important enough to be ongoing? Or might it be?
So again, this is the base adjustment to 23, so that is a discussion for 24.
Okay, so what we need to understand is that this it may come through in 24 or may not.
Something to look for in the budget. And then the rest are net neutral items. So it's just a flow of money. So I'm not going to go through the rest of those. So there's those 4 items. Again, I do apologize. We did not have the time to take these in through testimony because our committee was focused on the youth inpatient beds. We will answer questions as best we can. So does anyone have any questions on the 4 of these?
This is a really short BAA. I'm just making an observation. So I would just commend DMH for their great budgeting.
Yeah.
Their brevity.
You're right, Daisy, correct. So general fund equivalent for these 4, and I am completely rounding up, is $535,000 roughly. Not even rounding up, I'm just rough adding, bless you. So I am going to make the suggestion, not hearing any questions, that we accept these as written by DMH as requested, and move on to the topic of the inpatient beds. So shaking heads, yes? Does that work?
Yep.
Okay. So we're going DMH, we're going DEVA with those 2 additions. Now let's talk about the inpatient youth beds.
So is there any narrative on that? Is there nothing?
There,
Only the language in the,
there is narrative.
Yeah, the first one,
If you go to January 18th,
yeah, the
Oh,
18.
got it, yeah, thank you.
Which one is it on? The mental health budget adjustment narrative or the?
first one. Sorry, and I had it up and lost it, so let me find it. So this request, I'm going to take a step back and just remind us of the history. So a couple years ago, there was, and I don't know if it was an RFP or not, I don't think it was, But there was a commitment by University of Vermont Medical Center to build inpatient beds in Berlin connected to their hospital there. Because of financial pressures, they had to back out. And that happened, I believe, a year ago. So Department of Mental Health this summer, and I apologize, I don't know the exact timing of it, put out a request for proposal to solicit proposals from qualified healthcare organizations connected or affiliated with a general medical facility to provide inpatient psychiatric services for children and youth under the age of 18. So this was an RFP connected to a medical facility so that youth who may be experiencing needs and treatment, both for mental health and some other co-occurring illness, could be treated effectively and bless you, and have a place to go. The only medical facility who responded was Southern Vermont Medical Center, which is in Bennington. They are currently doing a feasibility study, and that feasibility study is supposed to be done by the end of March. So there is a potential after the feasibility study, they say we can't do this. You know, we've heard testimony over the years, and we have here as well so far this year, where, you know, reimbursement rates are really low. Commercial reimbursement rates and Medicaid, and, well, this is Medicaid rates, are really low. And being able to provide youth a place to be treated, you know, with the right care at the right place, unfortunately loses money for the facility who does it. So that's a little backdrop to this. So what Department of Mental Health is saying is they're doing the feasibility study, and we believe that this money, $9.255 million, should be held to be used to help bring this to fruition with Southern Vermont Medical Center. So that is the proposal on the table. We've all talked about this. We've had a lot of testimony. A lot of people have said we need it in the central region. We need it in northern Vermont. Why is it going to Southern Vermont? And at the same time, all of those people who testified said, if that's the only place that can do it, we need the beds. We need youth to have the capability to receive the right care when they need it, even if it's in Southern Vermont and we have a transportation issue. So I'm going to stop there and let's have a conversation about it. What people think, where they want to go with this. Leslie.
I just need some clarity. If we approve the 9 million for a feasibility study, it is only directed towards the Bennington?
So the 9 million is not for the feasibility study.
Yeah, okay.
So the feasibility study is happening.
Yep.
The 9.5 million will be to assist with bringing these beds online.
But then the beds would have to be in Bennington, even if the feasibility study says this is not a good thing for us?
So that is a decision point for us.
Okay.
We can put in language, as we're doing on the DEVA budget, that puts some guidelines or whatever your goalposts around the use of the money. Bumpers,
Swim
lanes.
posts, I don't know, guidelines, guardrails. That's
I have a question and a statement. So I noticed on the memo, it says 10.5 million. So I'm just confused, because you're saying 9.5 a second ago, so I'm wondering.
9.225.
Then what is the 10 point, so I want to be sure I'm looking at the right paperwork here. We have a memorandum from the Commissioner, Youth Inpatient Facility dated January 13th, 2023.
So-
Halfway down the page says 10.5.
Yeah, so Southern Vermont Medical Center included cost estimates to launch and ramp up at 10.5 million over 2 years. That is what Southern Vermont Medical Center stated. Department of Mental Health is only putting 9.255 into the budget.
Yeah. So thanks for the clarification. We obviously heard testimony, particularly on Friday, where they said, as you just said, it'd be better if this was somewhere else. And I agree. However, we've also heard testimony after testimony about children boarding for weeks in emergency homes. I learned over the weekend of a child in my district who is currently in Florida because that was the nearest bed they could find. Florida is a lot closer than Bennington.
A lot further than
Which Florida? Which Florida, exactly. Excuse me. So it's a lot closer than Bennington, but my point being that, yes, I would much rather see this somewhere else in the state, but I don't want to have a poison pill. I don't want to do anything that could prevent us from having more beds for youth so they stay in Vermont, closer than an entire seaboard away from their family, in their state, close to their community. I think all of that is really valuable. So, again, with all the respect to everyone who came to us and said, it'd be better if this were somewhere else, I agree with those people, but this is the only place in Vermont that bid. And it wasn't like this was a secret. It wasn't like no one knew. I mean, every hospital in Vermont knew about this. This is the only one that chose to do it. So I would recommend that we approve in full.
Great. Alan?
I got a comment, I guess.
Great.
Number one, this was in our local paper up home a few years ago. And I first talked to that and somebody said the university in Burlington was interested. And it was all about financing, so it didn't work out. So they were interested in having this in Burlington. That's correct. Number two, I also worry about the unintended consequences. If we spend this money in Bennington, because you're talking the majority of these people are coming from north to south. And are we going to come back and after this is built, say, oh no, now we need one up in Burlington? And did that have to go out? My question is, did that have to go out to bid? So I've heard that those things did not, other places did not go out to bid. It was a addition to their hospital.
Right.
So I'm a little confused on all this.
So I'll try and answer a couple of those questions, maybe backwards. Did it have to go out to bid? I honestly don't know the answer to that. I don't. I will say, in talking to Boz, in talking to UVMMC, and recently both Senator Lyons and I were invited to a hospital CEO call. We did an introductory call with them. No one else is coming to the table. At this point, UVMMC is not coming to the table. The only one who has is SVMC, and they may or may not be able to do it. As for your question of, do we put the money down there and then decide we need another one? Absolutely. We need more support services. So we need the appropriate number of beds and we need community-based services. I don't view this as a one or none. I view this as a step to have the correct facilities, appropriate care for our youth, and continue working with Department of Mental Health and the administration on what else is needed. We have not gone over this because it was a couple years ago. I'm actually going to pull it out again, and I suggest you all do as well. There's a Vision 2030 that DMH put together, which sets out what they think we need for a system of care. And that was before the pandemic. Pandemic has just made it really worse. And we can't keep letting kids and adults sitting in hospitals. So, I don't know if that answers your question, but in my mind, it's
needed. You don't have to sell me on that part.
Yeah. It's an and it's an and. It's not an or, it's an and.
As far as going out to contract, no, correct me if I'm wrong, isn't an RFP, when you send out an RFP, you send it out to a lot of people.
Yes.
In the response, that is a contract. When you respond to that,
No,
to do something.
they do is they put forth a proposal. And so if you have multiple, like we just did.
Yeah, but if you only get one,
You still negotiate a contract.
oh, you still have to do that.
Oh, yeah. Oh, yeah.
After they-
You might look at the proposal and be like.
Who are you gonna negotiate? Just that one group, right? Because they're the only ones that,
Plus you have all your standard terms and conditions that the state has. Oh, you still write a separate contract. You look at our RFP that we received from RAND, childcare, it looks different than the contract. But it matches it because we like what they're proposing, but you still have to write a separate contract, even if it encompasses what was in there.
And SVMC could come back and say, we did this
feasibility
study, we can't do it, or we can't do it unless we get another X amount of money. I mean, so they're not tied to anything at this point, other than doing the feasibility study.
Okay.
Alyssa?
Are we soliciting comment?
Yeah. Yes.
So I wanted to say a couple things. I feel very strong about supporting this. All the reasons why everybody thinks it's a bad idea, I completely agree with. It's in the wrong place. It doesn't serve youth under the age of, I think, 13, maybe. It's an adolescent, not a
Right,
young.
12 to 17, yeah.
Yeah, 12 to 17. But it's a really important signal. If this is the best we can get right now, it's an important signal that we are doing something, that we care about this, that we want to make change. And there are so many other places where we need to go and fill in as well. It's not like this is a one and done. And then I wanted to say something to both the committee and anyone else that's listening, maybe. We talk about our hospital system and our hospital system here in the state. And they serve their communities. And frankly, I understand all the reasons why, but the fact that one hospital came in and responded to this, and that one actually had responded and then withdrew. This is about serving our communities, and I think our hospital systems sometimes need to think about that. I understand the financial pressures, and this is what I want to say to the committee, because we will talk about this. We will talk about this with VNAs and transportation and a host of other services that we provide. Nobody is responding to this because we do not reimburse the amount of money that it costs to take care of these children. And I guarantee you that if the reimbursements were equivalent to some of the surgical fees that we see, that you would have certificates of needs to build entire wings onto hospitals. So when we start talking about all these things and we start talking about reimbursements, it's about what we value. And if we say we value something like this, then we need to actually pay for it. And I'm fully in support of this.
Thank you. Art?
I want to follow up on what you just said, Alyssa. When you say because I have just struggled to understand this. When you say reimbursement, what exactly do you mean? Can you give me an example of what it is, just so I understand it? Because I don't get reimbursement.
How much does,
I understand what reimbursement is, but in the medical world and what you're talking about, what do you mean?
how much does the hospital get paid on a daily basis to take care of this child who is in an inpatient setting?
That they get paid from commercial payers, Medicaid, and Medicare.
Yeah.
This would not be Medicare, but.
So no one pays full amount?
They don't technically, I don't know rates, but I'm pretty sure, it's very close to cost of care.
Okay, you don't need, So I'll bet you, because everybody does it, you go to a dentist and have a tooth pulled out, they'll only pay a certain amount. And then you're on the hook for the rest, because it's a standard rate thing. I assume it's kind.
It's, in hospitals, it's complicated. Different payers will pay different reimbursement rates for the same service.
Okay.
Without getting it muddy.
Right. Is it based on a national average?
No,
It is not. Okay.
negotiated,
I don't want to go into
and
the,
it's complicated.
okay, so we're operating at a loss from the jump. Basically, yeah. And that's a disincentive for anybody to build a wing onto their hospital. Okay, thank you.
And I will say, with the hospitals I've talked to, and you can ask them yourselves, they want to do it. You know, they're not, UVMMC was not happy that they backed out. You know, none of the hospitals want to see what's happening to Vermonters. But there's only so much that they can do without support. So I just want to be clear on that.
Well, let's go a little farther. What does Bennington gain from it? Do we know? I mean, why are they doing it?
You know, we did not hear from them.
Yeah, right.
So
We saw the RFP though, it got their response.
their response came through in the RFP. What I heard was that they need to help the people in their community.
Okay.
If they can make it work.
Altruistic,
Yes, if they can make it work.
okay.
That's an if. I mean, that's important, right? Because we've already heard about, hospital sustainability and our concerns about margins and how much they. Uh-oh, I wasn't sure what you meant, Paul. Okay, whatever. But you get my point.
Yeah.
They have to be concerned about their margins. Would a business take on a line that they couldn't afford and lose money?
That's why I asked the
That's what's being
question.
asked, so, yeah.
I have another question, fundamental question to this. In 2 and some years here, all I've heard is about beds. We don't have beds available. Do we know how many beds are available, not staff, but physically in a room for this demographic of children right now? And how many of those are staffed?
So we do have that information. It was in the Department of Mental Health presentation when they came in. They gave the total number of beds by facility and the number that are open or closed because there's no staff.
Really, they did give that.
For this particular population, which would be, co-occurring illnesses, there are very few beds because Brattleboro Retreat cannot take youth if they also have a medical illness. So here's an example. If someone has an eating disorder, so needs medical treatment, but also is suffering from depression and needs care for mental health treatment for depression, they can't go to Brattleboro Retreat because they don't have someone who can help them with an eating disorder medical diagnosis. And remember, Brattleboro Retreat is the only place for youth inpatient beds.
There's no other hospital that has mental health.
Sometimes hospitals will find a place for someone who needs care. I know UVMMC has done it. I'm sure other hospitals have. I don't know. I just know of one case that UVMMC does, and we'll let Mari talk in a minute. So, they're trying to do what they can, but no, there's no official place for this population. All right.
And the situation of having hospital units that are not designed and the staff aren't trained to take care of children with specific mental health needs is not a good one. In the pediatric unit at UVM Medical Center, it's designed, it's a beautiful unit, the staff are amazing. They do the best they can. They have taken care of kids with mental health needs on that unit, but it's not designed for that. Like I said, the staff are trained for acute physical health needs, not mental health.
Right. I thought though that I heard somewhere in testimony that there are some hospitals that have beds for that. None?
Well,
They have them for mental health.
they have psychiatric beds, yes,
But not for,
but
Not
not,
for kids.
not for
not
youth.
for kids.
Not for kids. Okay.
Any other comments?
Yeah.
Go ahead, Daisy.
I wanted to make this comment earlier when we were talking about how challenging it was to prioritize things, and I think it is also challenging just to make decisions, especially about things that will impact our system of care, because it's sort of like a rubber ball. When you touch on one side of it, it definitely impacts every angle on the ball, and moving forward with this project definitely impacts our entire system of care. And you always hope for the better, but you never know, right? I wish that we had time to really look at some of the legislative reports that are coming in. Lori mentioned Vision 2030. That was one that was delivered by statute a few years ago, and I noticed that the update from the Integration Council was just delivered last week or week before, and it's really good.
Okay.
And they have recommendations in it. And I wish for us that we can look at recommendations that come out of stakeholder groups like that, because there's such a good swath of stakeholders represented on there, from, employees in the healthcare industry to people with lived experience, other legislators, and folks with really wonderful perspectives on the way that the healthcare system in Vermont could better work for everyone. And so I'm just expressing, the frustration of weighing in on such critical decisions like this without having had an opportunity to really look at, the informed recommendations from groups like that through looking at their work, like these legislative reports. But in lieu of not having had time to fully digest those things, I think as a parent and as a family member of people who have needed critical care like this, I think, this decision is one that is perhaps a little bit easier for me, and I absolutely fully support it. I think Alyssa articulated maybe best what I feel about it. It's unfortunate that I would just leave it at that. I fully support it, and anything I can do to help it happen in more places in our state, I would do that, because I think no child should have to wait. And I think it'd be better if no parent had to take their child to a place like this, or their youth, ever. But we are lucky to have people who do this work, and we're lucky to have providers who step up and try their hardest to do it for us. And I just extend a thanks to them.
Thank you, Daisy. And we will work through some of those recommendations that are coming in now from the various committees and councils that have worked. Mental health integration is definitely one of them. We did take good testimony on this though as well, even though we don't have the full picture of the, where we're moving to. And honestly, I think no one has a full picture yet because of the pandemic. We're having to adjust things and look forward. So, but thank you, Daisy. Leslie?
I'm just looking for clarity in our decision-making right now. I want to understand what decision I'm going to be making. I mean, I'm going to support, but
So I'm throwing out.
Let me just say, I want to understand that if we say, yes, we support $9 million for youth bed, that it's only in Bennington. Or could we say we want them to put out a whole new RFP because we didn't get the results we wanted and there's an opportunity to ask again? Or we say, well, and people have talked about this already, we are disappointed about it being in the southern part of the state. We really want it to be the northern part of the state so it balances beds we already have in the south, whatever, blah, blah. So can we look at all those different options? So what I'm hearing is that we're not wedded to the RFP from southern Vermont necessarily.
I believe what I would like to put forward is that we agreed as a committee to support the 9.255 to go to Southern Vermont Medical Center based on the RFP that they responded to. Should the feasibility study and a contract be developed with DMH? And we want to ensure, and the words don't matter, the intent matters at this point. And we want to be assured that should Southern Vermont Medical Center not be able to do this project, that money is held for the purpose of youth inpatient beds while Department of Mental Health puts out another RFP, or there's a next step on how we're going to achieve these. And that the money stays for this purpose.
So I think it's fantastic. I really like that the money stays for this purpose. But I think what I'm struggling with is I'm hearing from a statewide perspective, I've heard it many times, that the north needs beds, right? So we're saying that. But it sounds like if we go for the 9.2 million, we're committing to the beds at Bennington, or Southern Vermont, should they decide that's what they want to do. But I'm not sure I feel that comfortable with that. It's a process problem I'm having.
Right.
So I'm just wondering if there's a way or not, that this is Southern Vermont, period, no further conversation, or is there an opportunity? I want to hold the 9.2, totally get it with it, but.
I think we need to put in the language what we've been talking about, that this is one place and we need more. We need the state to work towards a plan with us on how we ensure that all Vermonters are being served. I feel because, and this is my personal opinion, the committee doesn't have to agree with this, because Southern Vermont Medical Center is the only entity that responded to this RFP, that we give them the ability to craft a plan. And if it works, the beds need to be done. And we keep working on what we're going to do in the rest of the state and what we're going to do for community-based services. That is my personal suggestion or perspective. No.
One other thing you can do is you can require a report back. You can ask for them to, by a certain date, to send a report saying this is where we are with the feasibility study, this is moving forward. And if they're not moving forward, what their plans are going forward. So that way you're kept in the loop of what's happening.
Great idea.
I would love that.
Hold on, go ahead, Alan, and then we'll come back to you, Leslie.
Yeah.
Does anybody tell you a timeline if everything goes according to?
I think it was in
This fall, maybe?
I think it depends on what the feasibility study tells them on what they need to. I heard conflicting things. Daisy, we see your hands up, so 1 second. I lost my train of thought. I've heard conflicting things of if they're building a new wing or they're repurposing. So I think timeline will come out of the feasibility. One of the things that I feel really strongly about, and Alyssa alluded to this, is that we are sending a strong message to our healthcare system by supporting this money. And to families in Vermont that we know it's not the best. Central Vermont or Northern Vermont would be great. But we also know that our healthcare system and the people working in it need to know that we are focused on helping them. And that families need to know that we are focused on helping them. And if we don't allocate this and at the same time, say all the things we want to say, I just think we're doing a disservice to the people who are working in Vermont. It's just me. Art, and then Leslie. Oh, sorry, I'm sorry. Daisy.
Yeah, Daisy.
Daisy, and then Art, and then Leslie.
You know what it's like.
I forgot my question.
Kidding, class.
I'm
Raise your
sorry,
hand all
we
day.
can't see your hand, so Claire is letting us know, so we'll come back to you.
Oh,
We're gonna
good,
do
good.
Art and then go back to Daisy in case
Yeah.
somebody remembers.
Lori, I don't understand why this needs to be a BAA item and not a budget item for fiscal year 24. We're not gonna do it until 24. Why would we muddy up the water with it being in the BAA? I don't get that, right?
You want to take that or?
I'll take it from my perspective, but Nolan can answer from the financial first, go ahead.
No, you go first, and you might probably say the same thing.
So, I don't know, so my, why I would like to keep it in the BAA and not kick it down to the budget is because they are allocating the money, and so we need to take it and say, yes, we need the money for that. If it waits till budget, who knows? And who knows after it comes out of here? Whatever recommendation we give, it still goes through appropriations and the House floor and the Senate. It could be taken out at any point in time, at which point I'll be back fighting for it, for the budget. But in my non-financial viewpoint, this is based solely on my desire to help the mental health community. The money's there. They're suggesting it. Let's use it.
Well, what do you mean the money's there?
Yeah,
Well, go ahead.
the other piece too is, the part of the testimony I heard is that, they want the money there so that when everything comes through, the money is there and they can go. Versus if you wait for the 24 budget, the money won't be available until July 1.
And then if it's not in the budget and they say, oh, well, we're going to wait till next year, we're going to wait. Well, we're not in these seats until January, and then you have to wait for the next budget.
But we're gonna decide on a budget before we leave this building,
But they won't
right?
get the money until July.
July.
So if they finish up the feasibility study in March or April and they say, great, let's do this, they can't start until
Right.
July. So that's,
Okay.
Right.
Okay, but I look at budget adjustment as, okay, we plan to do this, but it costs too much, so we have to add. This is a whole new project.
This is a new project
Right.
because we need to help
No, I
our
understand the
families in
need.
Vermont.
I see that, but it's still not an existing thing. We needed nurses and we had to get travelers, so that's an additional money we have to have to function, cause healthcare to function. This seems to me, and this is only my opinion, as a new effort that really doesn't belong in the PA, but.
I will agree with you. I mean, oftentimes there's new policy that the administration puts in and we say that needs to wait till the budget. But I think for what Nolan said and,
Okay.
so if the feasibility gets done March 31st and let's say, Southern Vermont Medical Center or someone else says, oh, well, based on that feasibility study, we could start construction on April 15th. I don't want to wait till July.
And Art, if you remember, the UVM part was supposed to start it. So in that sense, in my mind, it is not a new project.
Good point. Joe, and then Brian, and then Mari.
No, I'm just scratching my head anxiously.
Oh, sorry, Leslie, you were next. I'm sorry.
I just want to clarify, this is only clarification. So the beds, 9 beds-ish, $1 million a bed, that's a lot of money. What happens should we approve of this and we realize, we know that we need beds in the northern part of the state, and then we're going to have to another unit, or hopefully, once we prove that we can do it down here, that they can do it up there, and then we're committed to yet another unit up in the north, which I think should be anyway. But I'm struggling with that balance of having to add another 9, 10, whatever $1 million again.
I don't have an answer for you. It is a struggle, right? Some in the community would say we don't need any beds. Some would say we need a lot more than 9 beds. And we're going to build in the north with another project.
Do we, if I may ask, do we have a sense from DMH how many beds they think is needed really statewide?
So I don't have the answer to that. I would believe it's in that 2030 vision.
Thank you.
Joe.
I have a question and comment. Is the question first, as is purely just information, because I don't know, is the BAA top line a revenue neutral document in the sense that for every plus there is a minus, or can it also have revenue, a need for revenue generation inside of it? Okay, that's fine.
One of the things with the budget adjustment is you also know what your revenues are going to do too. So sometimes your revenues come in higher, then you can say, great. Introducing a new revenue in an LBAA, well, that's a policy decision. Sometimes the legislature can justify it, fiscal timing, other times can't. It's whatever you decide.
Okay, thanks.
It has to be. But as you know, we do pass balanced budget, so.
Yeah. So I guess my comment is, I know we've had a lot of discussion about northern Vermont, southern Vermont. There's also central Vermont. There's also an eastern and western Vermont.
Exactly.
And it is, as someone who's lived both in western Vermont and eastern Vermont, crossing over can also be difficult.
Mm-hmm.
You have to go over the mountain. Which is why we had the mountain rule back in the 1700s and early 1800s. And so. Well, it was a lot harder then than it is now. I assume it is. 89 helps a lot.
What they say about assumptions.
Yeah, but so I again, I hear what everyone says, and I agree with the testimony we took and everything like that. But it's just that 9 beds is 9 beds is 9 beds, and it's 9 beds in Vermont, and it's 9 beds that's needed. If I had. I was king for a day. Yeah, I'd put it somewhere else and say, no, it has to be here. It has to be there. But this does serve the western part of the state, which is, I think, important. So I don't know. Just in my opinion, let's not the perfect be the enemy. Let's not let the perfect be the enemy of the good. And let's do what is needed to serve youth and families in Vermont. And let us use this feasibility study and let's use what we learn over the coming months and years to, fight for more beds in all places in Vermont. But let's go with the bid that's here and the thing that's in front of us. And let's accept as a committee that we know from everything we've heard how necessary more beds is not in southern Vermont. Let's do what's needed. It's better than Florida.
Yeah, that's true. Thank you, Joe. And I will just add to your statement, and we need community-based services too.
Yes, exactly.
It's the whole gamut that we need. Okay, so Daisy, did you have anything last to add before we do a straw poll?
No, I think everybody said it.
So I'm going to suggest we do a straw poll that we are accepting the Department of Mental Health overall changes that we just walked through. And we are accepting or recommending the 9.2.55 million for youth inpatient beds. But I'm suggesting that we change the language. So the language in the document is to continue construction or something. It doesn't make any sense.
Are you looking at the?
I'm trying to find it. Can you read it?
Yeah, it says it's on line 30, blah, 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 the amount to the Department of Mental Health to continue construction of the Southwest Vermont Medical Center Youth Inpatient Facility.
So we need to change the language anyway, because they haven't even started construction. So I'm going to suggest, and I'll work with Ameren to get this in a probably much better said than I'm going to say, that we recommend that the 9.255 be used for additional youth inpatient beds if Southern Vermont Medical Center, through the feasibility study, determines that it is a project they can do. Period. We strongly support, use of funds for facilities in other areas. Talk about, the struggle we're having between them. And should Southern Vermont Medical Center decide they cannot do the project, that the money is held for the purpose of additional youth beds with the Department of Mental Health through another process. And then add language about requiring a report back on the status of the feasibility study and next steps. And, we'll pick a date. I think it's supposed to be done at the end of March. So I would like to see a report, while we're still in here, mid-April, I would say.
Lori, I'm looking in Act 167 right now to see if they already have a report required.
No, they would not enact 167.
What year is she talking about?
Are you talking about the last year's 167?
Yeah, I saw that was referenced, I thought, in the RFP.
So we'll look at that before we do the language with Ameren. I don't remember that being in 167. But it wouldn't have been specific to the feasibility study, which is what we want to hear about. Progress report on what's happening with the RFP. So again, Ameren will say that, I'll work with Ameren, we'll come up with much better. I'm not a lawyer like Joe. So with elegant words. Anyway, does anyone can we take a straw vote on that? Okay, all in favor? So it's the majority. So that's what we will recommend. Thank you, everyone. This was a good committee first process. We'll be doing it again with the budget. But that's a whole other process, similar to this, but we'll talk about it once we start going through it. So if it's okay with everyone, I and whoever here in leadership will work with Ameren on getting our written responses. We'll get it over to House Appropriations and we will make sure that all of you are copied on it.
We get to see it first?
If you would like to see it first, we can send it to you tonight, but we don't really have time scheduled to wordsmith it. But yes, we can definitely show it to you. So since we've all approved, it would just be the wordsmithing piece of it. And we'll send it to you. Great. So we are back here tomorrow tomorrow is the UVM-MC legislative breakfast that you all are invited to. Obviously, it's a Chittenden County focused event, but they did open it up. So that's at the Plaza tomorrow at 7:30 to 9.
I know.
It doesn't,
I'm showing up at 8:30.
I don't think remarks, I don't think start till closer to 8, if you want to sleep in a little bit. And then, but we'll leave that a little bit early, who's ever there to come. And tomorrow we're going to do insurance regulation. Thank you, Nolan. Insurance regulation. And then we have some more introductions in the afternoon. At 11 o'clock, we have the University of Vermont Health Network's new president, Sonny, and I'm going to pronounce his name wrong. I think it's Epen, but I'm not sure about that. But we'll be meeting him at 11. He will also be at the breakfast. And in the afternoon, we'll have Ameren here to walk us through Act 167, what was passed last year. Because then on Thursday, we're having joint testimony with Senate Health and Welfare and Human Services on the first two sections of Act 167 to get a progress report on where things stand. And then later in the week, we come back to mental health with Department of Mental Health talking about children's services. We also have the Brattleboro Retreat coming in. And then we will have Vermont Care Partners and Mad Freedom come in on Friday. So we will come back to focusing on mental health and this conversation was great, right? So we all have a lot of questions and what's the future, and we'll keep taking testimony to try and get there.
The joint meetings are here.
The joint meeting, we will be zooming in, yes.
What time tomorrow morning?
So tomorrow, committee starts at 9. Yes.
The other thing starts at 7:30.
Yeah, that's it.
And on Friday afternoon, thank you for that reminder, because it's not on here yet. Friday afternoon, we will be working on and finishing the guiding principles that Topper, Leslie, and Joe worked so quickly on and have a great first draft, which I have not worked as quickly on. I will get it out to everyone and we'll finalize those on Friday.